So for this case, I grabbed kind of a fun ECG, and I know when you look at this, you're probably asking yourself, like, why do you feel like this is fun? This looks terrible. There's so much artifact. You can just see the isoelectric line just kind of fluttering all across the paper with no like semblance of stillness, and that's true. However, there are some good learning points to be gained from this particular 12 lead. And I want to reinforce that just because something looks bad in the sense that the image that you captured isn't great doesn't necessarily mean that you don't have the ability to use this information and formulate a differential or even formulate a diagnosis when it comes to looking for cardiac abnormalities. So as you can see, in this particular case, I've opted to leave the computer interpretation open because this is going to be a classic case of man versus machine in that we're going to prove the machine wrong and point out why this is misguided as far as some of the, or rather the absence of diagnostic accuracy with this particular interpretation. So having said that, let's move on. So we've got a 66-year-old female, and in these types of patient populations, remember, they oftentimes present atypically, and so we should have a very low threshold to perform a 12-lead ECG on somebody who is over the age of 50 and maybe has some like vague symptoms. And let's say for, argument's sake, she's got some like nausea, vomiting, maybe she just feels kind of weak, and the origin of her symptoms are not really well known. So when we do the 12-lead ECG, we'll do our normal approach. We're going to look for things like the rate, and in this case, the rate is calculated by the computer at 72. We can look to see how accurate that is. So we'll see here, take this R wave. I'm going to blow this up for you. This R wave, this is going to be 300, this will be 150, this will be 100, this will be 75. And we're a little bit short of that. So yeah, 70s seems like a good, accurate representation of what this heart rate is doing. From there, we're going to look for our intervals, and more specifically, we're going to see if we can, or make sure that all of the appropriate waves are in fact present. And because of this, wavy baseline that we're seeing out here in lead 2, it's going to be hard for us to find clear evidence of P waves. So let's scrutinize some of the other leads and see if we can't not find what we're looking for. Yeah, not a whole lot of prominent P-wave activity. However, it does appear that perhaps these little blips right here are probably our P waves, and they're just pretty low voltage. But you can see that as far as this and this is concerned, the distance between this would-be P wave and the QRS complex is essentially the same. And that can be a good, strong indicator as far as regular P wave activity. If you see something that could be a P wave or see something that you're not really sure is a P wave, measuring the distance between those intervals can be helpful. And then if we move out to V4, it looks like we've got a more clear, concise image of a P wave, as you can see right here. And then you can appreciate that the distances between these P waves and QRS complexes, as seen here, seems to be pretty normal and pretty regular, and I think we can call this a sinus rhythm based off of this. Maybe getting close to a first degree AV block, but it's a little difficult to tell for sure. All right, so moving on. From there, let's look for signs of axis deviation, and it doesn't look like there's an abnormal axis. I recognize that this is kind of wavy, but it seems like if we look at AVF, the majority of the QRS complex is a positive deflection. And then if we look at lead 1, we can see that the majority of the QRS here is also a positive deflection, so we have normal axis. And let's now interrogate this thing for ischemia. And so what you might be noticing is there does appear to be some ischemic changes. Your eyes are probably gravitating towards lead 1 and lead AVL. And if we look, we can see that the ST segments in both of these leads do appear to be depressed. Now, again, the isoelectric baseline is a little bit wavy, but there are some characteristics of ST depression that are not necessarily going to be altered too much by a wavy isoelectric baseline. And part of that is just this kind of sloping, scooping looking T wave as it starts off low below the would-be line and then kind of slopes back up is a good indication that is an ischemic change or a reciprocal change. And then again in AVL, anytime your T waves are inverted in AVL, you should be concerned. If you have T wave inversion with what looks like some ST depression, granted, you know, the baseline's a little off, so this is like maybe 0.5 to 1 millimeter of ST depression. You should be concerned, added to the fact that we have abnormal T waves here and abnormal T waves here, and if you should recall, leads 1 and leads AVL are both high lateral leads, and so they are contiguous with one another. And when you have contiguous ST depression, you should be concerned about those findings being a reciprocal change, and the reciprocal of the lateral leads is going to be our inferior leads, and let's take a look at what those are doing. So arguably, of the wavy isoelectric baselines that we have here on this 12 lead, leads 2 and leads 3 have the worst, and AVF is not so great either. But there's a couple of interesting things within these wavy kind of garbage tracings that we can gain in order to help reinforce our suspicion that this person is having an MI. First things first is the T-wave morphology seems off. Now, I'm not talking about like this weird, like loopy downward, whatever. I'm talking more about this complex right here. And if we take a good hard look at this complex, we can see that not only does the QRS complex seem small in amplitude when compared to the T-wave, which is an indication of a hyperacute T-wave, but also the T-wave itself, this being the J point, it has a bit of a straight line associated with it, and it almost looks like a check mark. And so when T waves start to straighten out or become a little bit more convex and less concave, that can be an indication of ischemia and infarction. Remember, if you have a convex T wave, that's a sad T wave. If it's a concave T wave, that's generally a pretty happy T wave. And in this case, we have a straight T wave, and so it's that weird little emoji with like the slanty face, which is kind of not thrilled about life. But T-wave morphology and the structure of the T-wave can be very important as far as helping us determine if there is ischemia. And if we look at the other contiguous leads on the inferior side, that being lead 3 and lead AVF, we can see that we do have some T-wave flattening going on here. There's some T-wave flattening going on here. And in the areas where it seems like there's a bit of a straight line that we can work off, it does appear that there is some elevation of greater than 1 millimeter in some instances. But again, this is not really a slam dunk because of the tracing quality. One other thing I would like to draw your attention to is going to be the Q waves in lead 3. Now, Q waves can either be normal variants, so nothing to be too concerned about, or they can actually be pathologic. And so what determines pathologic Q waves versus normal variant Q waves has a lot to do with the size. And there's a couple of things that I would like to leave you with here regarding the size of Q waves and their relationship to either being sinister or normal. And one of those is going to be the size. And so for a normal Q wave, you wouldn't expect it to exceed 2 millimeters of distance. And this one, as you can see, far exceeds the 2 millimeters. One of these small boxes, remember, is a millimeter. And if we look at to where the PR interval begins, to where it enters the QRS complex, we can see that the Q wave accounts for 1, 2, 3, 4, 5 millimeters. And so those are some very large Q waves. Another thing that points you to these Q waves being pathological and not just the normal variant has to do with their size in relationship to the overall QRS complex. And so generally speaking, you would expect the Q waves to be less than or equal to, or let me rephrase that, you would expect the Q waves to be tiny. However, if the Q wave exceeds or is, let me rephrase that, is greater than or equal to 25% of the overall QRS complex, then that is very concerning that this is a pathological Q wave, more specifically one associated with acute inferior MI. So based off of the information at hand, based off of the history of present illness, maybe you know your patient looks kind of sick, looks kind of unwell, this has this like unshakable feeling that she's a little bit not doing so hot, it would be fair to manage her for an acute coronary syndrome based off of these findings, that being the ST depression and inverted T waves seen here in AVL and in lead 1, and then the straightening of the T waves, the hyperacute T waves, and the large daggerish looking Q waves that have developed. All of these can lead you into the diagnosis of STEMI, and this should be enough to at the very least, warrant a transport to a hospital, specifically one with PCI-capable services. But remember, if you get a crummy-looking 12 lead, take steps to remediate that and get a cleaner one. But if it were me, I think I have enough information here at hand to not only manage this person for ACS, but also to activate a STEMI alert.